I'm the lead information officer in the Sussex HIS, responsible for stratification services across East Sussex. It's a tool used by the community matrons in East Sussex, the ones that Hazel were referring to in Kent, and our North East Essex colleagues. It's also integrated into our clinical dashboard. It's very much supporting care in Kent and Sussex and in North East Essex. Just a brief overview about how and who and what we identified during the process. It wouldn't be a risk stratification presentation without that Kaiser-Permanente triangle, so it's there for look and feel and to make me feel secure. But how we go about it is we take the whole population and risk profile them. We take 3 years worth of clinical data and putting it through an algorithm, predict, and in the case of the Sussex combined predictive model, we're predicting the chronic admission of patients. In Essex, we're also developing another model to support the risk of A&E admissions, and as I think Sue mentioned in the video, we're working with East Sussex to include social care data as well as GP data. So moving forward, and the next few slides were there just in case the video didn't actually work. There's the patient list, the clinicians given the clinical risk, the difference between the risk this month from last month. They're given a trend, they're given details of the long-term condition and any comorbidities, and a summary of all the events that have occurred. They can plot the actual trend of the patient, and they can see the profile of their practice or their virtual ward or their CCG, and we can apply that to a geographical tool to plot that, but it really needs to be bigger than practice. It needs to be across the PCT to be of any value. The video touched upon what the clinical matrons are doing in East Sussex. I was fortunate enough to go to the telehealth event 2 or 3 weeks ago, and I was introduced to Harry, and he said thank you. I think Harry was well known to the clinicians even before the Sussex combined predictive model was introduced to it, but it was a very good and pleasing experience. We also received this email from a GP from Essex. What the GPs in GP practices in Essex were asked to do prior to Christmas is to review all their very high risk patients and high risk patients. And I think Hazel alluded to the contact. I mean, what that process allowed us to do was the clinicians were able to contact the very unwell and identify obviously the medical issues that patient may have, but equally some of the caring and carer issues that they may be exposed to over that Christmas period. Obviously they were resolved, and they were able to sort of identify to the out-of-hours services potential use of the services over that time period. And receiving unsolicited emails like that were very good, and it shows that risk stratification is working. Another byproduct of that is actually presenting an event summary to clinicians. So clinicians can see the acute and community events going on. As I mentioned, social care will be introduced to this in East Sussex, and in Essex we're working to include GP data in the summary. Crucially, moving forward, I'd argue we need some pathways and some national pathways, and if at the very least get some Sussex pathways together to help support what good care and what good telehealth looks like. Clinicians are using that now to look at the frequent flyers, those people who are unnecessarily going to A&E, and equally trying to map out the care pathways themselves. And if there's anything you take away from the risk stratification presentation here, it is that the clinicians out there are prioritising and targeting care interventions now. The one issue, and this is perhaps where I get more and more provocative, they are actually targeting face-to-face care, and we really need to give, I think you mentioned a toolkit, the tool set to our clinicians around telehealth to allow them to prescribe telehealth, not just face-to-face care. As a technologist, I feel it's important for me to say, one bit of technology doesn't fit all cases, and there is that plethora, and I'm sure we'll see in the foyer different technology that can be used there to not just support telehealth, but the self-management of patients, and that can be reflected not just in a condition, but in different stages of the patient's condition. And equally, the use of digital TV that David mentioned in helping to prevent and educate patients, clinicians, and indeed carers. And the final thing, which I think Dr. Bow and Adrian are going to talk about in more detail, is the modelling potential that you get. You can start to see where your problems are. You can do a very crude cost of what that care costs you at the moment. You can place the intervention cost in there and work out the cost benefit for some of this. And that's something that we do. It's something that Dr. Bow do very well. But as always, there needs to be a health warning. Risk stratification is just a mathematical algorithm. There is no clinical judgment in the development of that stratification. Okay? It's based on the last 3 years' worth of data. We do in Sussex use community as well as acute care. In Essex, we're using another permutation, acute and GP practice data, and in Kent we're using community and acute care. So risk stratification alone isn't good enough. We have to maintain that clinical judgment. Clinical systems you already have for case management and case finding. Clearly, there are other reasons why someone might be at risk of admission. The other bit that Hugh mentioned in terms of managing patients out of hospital, my team are already doing the urgent care dashboards in both East Sussex and Brighton and Hove, and we've integrated the risk score. But the risk score itself does have a time lag. It's based on data that is months old, not within the last week. And that's related to coding practices. We need coded information in order to generate that risk score. It is independently verified in terms of its predictive value. It's on a par with all the third-party tools, if not better, but I would say that, wouldn't I? But it has been verified by Dr. Bow colleagues as well as East Sussex Public Health. And our experience to date is that it is about huge service redesign and change. That, for me, is the largest component, but it does need to be underpinned by risk stratification, the telehealth technology, and an education and training programme for all. It can be improved. It can be improved. And telehealth, I feel, I'm pinning my flags to the mast here, can be used to improve that. Do we have a choice? Hugh's mentioned the numbers and the tsunami that is coming towards us, the increasing long-term conditions. The workforce isn't going to change dramatically because of the budgetary situation. So we need to change the way that we work. Risk stratification is out there, targeting, prioritising care, different interventions, and like Hazel, I feel that the telehealth is certainly out there, and solutions are available. So those problems are and solutions are there right in front of us. So we have to do it. We have to do it. So that's a plea from me to get a move on. Okay. So that's it from me.